Well, hi, everyone. Thanks very much for the introduction. I have this very egotistical sounding topic, how I do it, thrombectomy and distal occlusions. I did talk a little bit about this at the SNIS meeting this year, more at a conceptual level. For this talk, I was going to give you a little bit of a particular view as to our approaches. I will say, though, that there are multiple ways that you can deal with distal occlusions, just like you can with proximal occlusions, and so your approaches might be quite different. I think before we talk about the how, though, it's important to remind you of the why, and the why is that we know that reperfusion is powerful in its neuroprotective effect. You save a lot of brain, and we know that the more you reperfuse, the more you save, and therefore the better patients do. Very elegantly shown in the work from the OME's data set that Dave Liebskin led. And the reason that we don't achieve full reperfusion is typically because of distal occlusions. Distal meaning M3s beyond that, A2s and beyond that, P2s and beyond that. And so as we're striving to give our patients the best outcome, we need to stop thinking about the floor of 2B and start thinking about floating up to the ceiling of TICI 3. In the how we treat discussion and debate, there's certain sort of universal considerations. Anesthesia choices, what we do about spasm, which is much more common in those small distal vessels, the ongoing debate about balloon guides versus aspiration systems. We have prioritized the bigger aspiration systems over the balloon guides, and we use conscious sedation. We don't use GA. But you can see here an image of our stent retriever out in an M3, distal M2, proximal M3. And when you have the patient moving around, it's certainly a disquieting feeling, much more so than in a proximal vessel. So as we chase these distal occlusions more, should we be thinking about doing more GA, especially since we don't have evidence that it seems to harm patients, as we all feared? Those are universal considerations. We don't have much data to guide us for those, but we do have some data about the tools that we use, stent retrievers and aspiration systems, and even combination therapy. There's a recent paper from the Grady group, and I think Diogo is going to be talking a bit later, so I won't steal his thunder about that. But I think it's safe to assume that anything that we use now will get smaller and more effective, and so our tools to get distal will simply increase over time. What I wanted to show you, though, was the paper that really made a big impact on the way I practice in terms of approaching these patients. And this was an Australian paper, a busy stroke center, 250 cases a year. They had 14 patients with distal vessel occlusions that they approached. And they used something they dubbed the micro-adapt technique, where they took a headway 27 microcatheter out to the clot face. They put the headway onto pump using the aspiration pump system. Then they had an intermediate catheter, which they used Vaculox syringes on to aspirate, and they had a 5 French Sophia as their intermediate. They were successful in about 80% of those patients, and in 10 of those 11 patients, it was with a single pass. And I remember reading this and thinking, wow, those are actual distal vessels. It's not like putting a 3mm Trevo up in a A1 or A2. These are way out there. There's a P3 vessel, A3, you can see a right superior cerebellar artery, not a vessel that I personally would have typically chased. But if you have a tool like this, maybe you should. And so because of this paper, I started using this technique in our approach to distal thrombectomy. Now here's a case from last week. I took some pictures because I remember that I was going to be coming here to talk about this. And it's a patient with an ICA T occlusion. Stroke scale was 20. We use the same base system for all our stroke cases. We try and be as protocolized across our providers as possible. So we have a Neuron Max, we have a React or a Jet 7, they're both excellent systems, and the corresponding pump. And then we have a Velocity and a Synchro 2 prepared and ready to go. But what we typically try and do is just snake the aspiration catheter up primarily. We were able to do that in this case. She had pretty decent anatomy for it. And we did a single aspiration pass with that, and we got this result. And as you can see, we have a more distal occlusion and a significant wedge of tissue in this dominant hemisphere stroke. So using this technique, we have the Velocity already prepared, it's ready to go. We go back up with the aspiration catheter. We take the velocity out into that branch. We take the wire to the clot face. We don't cross the clot. We bring the velocity to the clot and bring the wire back as we are advancing the microcatheter. And then we take the wire out and apply suction. But what we do is we put the pump onto our intermediate, so we have a bigger and more consistent suction effect with that. And we use a 5 cc syringe, usually with a 2A, on the velocity, full tension on that, and then you hold it. And we wait for 1.5 to 2 minutes, and then we bring the velocity back, and we need to do that very slowly so you don't lose the clot. It's very rare that you ingest the clot. It's normally wedged into the end of the microcatheter. And just to show you what effect that had, we have reperfusion of that branch with that single pass. And this has been a pretty typical experience for us. So what's to love? Well, it's simple, it's conceptually simple, it's technically simple, and it's been very effective in our experience. It's low risk. This is a nice soft microcatheter. We're not trying to deploy a device or push something big far out. We don't have to cross the clot. I don't know about you, but I'd rather not go around an impacted and hard clot in a distal vessel around a turn if I didn't have to. For us, using our basic setup, there's no additional equipment, and that's always a positive, and therefore it's fast. What's not to love? You tell me. What if that fails? So we're out distal, we made a pass. I don't typically do more than one pass. If that fails, my threshold to use intra-arterial lytic has come down. I think we all sort of moved away from this because the devices were so effective. But remember, this is where the whole field started. And so we use alteplase dosed based on whether the patient is TPA naive or not. That's what we do now. What I'm hoping that we'll do soon is use tenecteplase. We've had a few hurdles as to why, and one of them is dosing. So we're going to look to see Bruce Campbell was here. We're going to look to see what Extend IA TNK2 shows and try and decide based on that what a reasonable dose is for IA use of tenecteplase. I did propose a trial design at the SNS meeting. I'd be happy to talk to anyone about that afterwards, but there's no time in today's session. And then I wanted to end just by taking a step back and commenting on the when to do it. So, this is a picture from my very first month or two as an attending. We had the Mercy device. You can see the old penumbra pump. Those were not the fun days of stroke like the days we live in now. And at that time, I'd often hear in my head that famous expression of Voltaire's, "Perfect is the enemy of good." And so the things that we consider when we approach these distal occlusions haven't changed. Is there parenchymal blush? Which branch is occluded and what's the deficit? An anterior frontal branch versus a posterior frontal branch? Different problems. How accessible is the lesion? How hard have we fought to get there in the first place? And what's the patient risk profile? Those considerations haven't changed, but my threshold to chase something distal has really come down. I'm much more willing to go after that. But I would say that if you hear Voltaire in your ear, it's probably a good idea to listen to him. And I'd like to end on that. So thank you very much.